Hello and welcome to Western University's Critical Care program. This is the first of our ICU Bootcamp lecture series, and we have the privilege of speaking with you today about airway management in the critically ill patient. Managing airways in critically ill patients can be one of the most challenging interventions that you can engage in during your ICU rotation. By the same token, it can be one of the most rewarding. Being able to help a patient breathe and offload their cardiopulmonary circulation through intubation is a rewarding task indeed, and when done correctly can result in an improvement in the patient's overall outcomes. One can start with a history. For example, what was their airway like before? Did they have any surgical procedures or radiation that alters their airway anatomy? If there has been recent surgery, it would be prudent to look at the preoperative record to see what type of airway adjuncts were used, or if the airway approach was easy versus difficult. Physical exam, looking at the mouth, looking at any obstruction, presence of false teeth, caps, crowns. Things of this nature are again important. Certainly mouth opening or restrictions with cervical spine, those are all again important considerations. And of course, just like any other medical procedure, preparation is important, and we will discuss this in detail with regards to pre-oxygenation, induction, and post-intubation care. In addition, the actual act of intubation needs to be thoughtful and prepared so that you can be ready for any adverse events and if you need to change to a different airway adjunct. Therefore, for intubation, just like other procedures, you need to have a plan B and a backup plan to that plan, a so-called plan C and D. And all of this goes in a way of making this procedure both safe and rewarding. Let's start with a clinical case. We'll use this case to also exemplify different parts of our discussion and return to the case at the end. Imagine a 65-year-old male with a past medical history of multiple myeloma, hypertension, hyperlipidemia, and GERD. Has a 3-day history of fever with new rigors, and the source of possible sepsis is thought to be urine. However, blood cultures are also pending. You are called by the critical care outreach team to assess this patient. After looking at the patient and looking at the set of vitals before you, you make a decision to intubate this patient. So what are the things you need to consider? Let's look at the vitals. The patient is tachycardic, hypotensive, febrile, and in fact exhibits abnormal oxygen saturation despite supplemental oxygen, suggesting that there might be a possible shunting process in the lung, such as the presence of pus or fluid in the alveoli. Other things that could of course be important here could be the presence of a pulmonary embolism, although that is less likely. So all things considered here, this appears to be a person with sepsis and likely septic shock, and your job is to perform an intubation both in a regimented and safe manner. So let's begin considerations of how to intubate this patient. Some of the steps that you'll be taking to safely intubate this patient include pre-oxygenation with delivery of a high FiO2 to the patient. In addition, possible pre-treatment during that oxygenation, such as analgesia, perhaps topical treatments in the mouth to further help the actual intubation. Then there is the actual induction and paralysis. Finally, the insertion of the endotracheal tube and post-intubation management. And we'll discuss each of these. Another simple way to break down your approach to a patient that you're going to be intubating is to think about 3 items. How are you going to pre-oxygenate this patient, and what are going to be some of the challenges in pre-oxygenating this patient? What drugs are you going to choose to do induction, and would you paralyze that patient? And furthermore, laryngoscopy and the actual active intubation, and what are some of the things you're going to consider if that attempt fails, or if you forecast that that attempt is going to be difficult from the get-go. Let's start with pre-oxygenation. This great diagram is the oxygen dissociation curve relating the oxygen saturation to the partial pressure of oxygen measured in the blood. What's important is that critical hypoxia starts to actually occur with SATs lower than 93%. This cartoon schematic outlines this. What is important is that under 88%, and certainly into the SATs of 60s, there is some element of critical hypoxia. So what you're trying to do during pre-oxygenation is to avoid any desaturation during the peri-intubation period. And we have ways of doing that. Turns out that oxygen can be delivered in various ways. Nasal prongs deliver reliably oxygen up to flows of approximately 4 liters, and after that they're kind of unreliable due to entrainment of air. Venturi masks work on an entrainment of air perspective. These are the masks that you see with little colored adapters in the bottom. They require a certain back-end flow put on that adapter to deliver a particular FiO2. Both nasal prongs and Venturi masks as sole oxygenation modalities are not sufficient for pre-intubation. Then you go to the non-rebreather, which is a mask with a reservoir delivering 100% oxygen. However, despite popular thought, a non-rebreather does not actually deliver an FiO2 of 1 or 100%. What is usually needed is a bag valve mask with also a reservoir which delivers 100% oxygen, and proper bagging technique, usually including a two-hand approach to holding that face mask onto the patient, and then bagging the patient if they're apneic, or bagging with their breath, such as an assisted bagging if they're still generating respiratory effort. This type of ventilation with bag valve mask and a PEEP valve, which provides positive end expiratory pressure when the patient exhales through that mask, reliably generate an FiO2 of 1 or 100%. BiPAP or CPAP can also be used. Another important consideration is that oxygenation, when performed in an upright position or semi-upright position, allows for greater oxygenation and greater apnea oxygenation. It just happens that you're able to expand the lungs properly, and most patients are able to deliver that oxygen correctly to the various lung elements to facilitate pre-oxygenation. This is a PEEP valve that sits in the back of a mask on a bag valve mask ventilator, and the way you turn this knob allows you to deliver a different amount of positive end expiratory pressure measured in millimeters of water during exhalation. And once again, PEEP is constant when you use non-invasive ventilation devices such as BiPAP, which is possibly why they're advantageous in certain situations, such as pre-oxygenating a patient who has COPD, asthma, or possibly heart failure. It is important to also note why we are pre-oxygenating patients. And the reason we're doing so is to denitrogenate a portion of the lung called the functional residual capacity. This is the volume of air left in the lung at the end of a passive exhaled breath. Denitrogenating that volume allows oxygen to flow into the circulation during periods of apnea. This brings us to another point that we commonly do and is now being done in most centers, which is apneic oxygenation through high flow nasal prongs even underneath the mask. As you can see here, this patient has nasal prongs with high oxygen delivery, which is occurring underneath the mask, and during laryngoscopy, this prevents desaturation. What's important as well, as alluded to earlier, is that ventilation is actually much more important than laryngoscopy and delivering the endotracheal tube. Patients can be compromised by lack of oxygenation, and in fact, if they're not ventilated with a slightly elevated PCO2, that is still well tolerated, just given the physiology of what happens in the body in the setting of acidemia. However, what's critical is actually oxygen delivery. And so proper bag valve mask ventilation is actually the most important step in intubating a patient. And as we advocated earlier in this podcast, a 2 thumbs down or a two-handed technique is probably the right thing for all critically ill patients. There is a great video on this, and we've provided you a link in this video. Another important consideration is that if the patient is already obtunded, for example, due to decreased level of alertness due to the underlying condition, or if they've already received induction medications and you're continuing to bag this patient with the assistance of the respiratory therapist, that adjuncts such as an oral airway, which is a piece of plastic placed in the mouth, and a nasopharyngeal airway, these again facilitate patency of the airway in addition to proper airway delivery. At times when there is concern of not being able to deliver an endotracheal tube, laryngeal mask airway can also be used to pre-oxygenate the patient, and is a very good rescue device in some cases. Let's now talk about induction medications and hemodynamics. There are various approaches to intubating patients when it comes to induction, also the use of paralysis. Now, your own approach will develop as you gain more experience with this, and you can refine your approach as you go on. The main element here is to avoid hypotension, and that can be done by generally being considerate of the patient's underlying physiology, starting hemodynamics, in addition to the agent that you're going to be using, and being cognizant of the things that that agent does. Let's talk about a typical intubation, and also we'll talk about some considerations for more advanced processes. It goes without saying that our priority during intubation is patient safety and survival, and we can accomplish this once again by being considerate about the medication we're using, being prepared to react to the consequences of that medication, and in addition, having airway adjuncts present. Other things such as no memory, pain, or awareness certainly are important, but do come after. There is no clear ideal method for intubating patients in the critically ill population. However, rapid sequence induction has been the most common used technique both in emergency departments and intensive care units. Other modalities aside from rapid sequence induction will not be covered in this podcast, and may be covered in a subsequent podcast on advanced airway practices. However, if you're interested in these, you can look them up on the internet, and there are several good sources with video. Rapid sequence induction had its birth in modern medicine to deliver quickly medications in rapid succession and to secure an airway. Another reason why it was developed is in the patient that is a high risk of aspiration or so-called full stomach. What rapid sequence induction means is that you are giving predetermined doses of medications in rapid succession and usually following up with a neuromuscular blocking agent. And the idea is that you'll get the ideal intubating conditions very quickly and be able to deliver that endotracheal tube. Advantages of rapid sequence induction are that it is well established, it can be used with limited spinal movement, and if done correctly, will result in less airway trauma. Disadvantages relate to the fact that medications are being given in rapid succession with predetermined doses, and the effect on hemodynamics may come to play in the post-intubation period. In addition, delivery of paralytic agent causes loss of airway reflexes, and in some cases this can potentially make it more difficult. However, by and large, rapid sequence induction is the standard of care and the most commonly used technique that you'll see. Let's talk about the steps in rapid sequence induction. This includes pre-treatment, the induction itself, and the delivery of muscle relaxants. Pre-treatment can be in the form of a combined topical or systemic analgesia. Topical agents include xylocaine spray and can be used to freeze the back of the mouth, including the upper portions of the oral pharynx. This usually can be an induction agent sparing maneuver, as the patient will tolerate laryngoscopy and endotracheal tube insertion better. In addition, patients that are shocked or obtunded may be able to have little or no medication during the actual intubation process, and once again, this is an important consideration. So for our patient, we will use topical xylocaine sprayed in the back of the throat, and this can be done in a generous manner with anywhere from 4 to 6 sprays. After that, fentanyl can be given systemically at approximately 2 to 3 micrograms per kilogram. It's important to note that this dosing of fentanyl is the typical pre-treatment dose quoted. However, most of these drugs, when used in combination, can have more pronounced hemodynamic effects. And in the case of a shocked patient who may be induced with propofol, you may be able to get away with a lower dose of fentanyl, for example, 0.5 to 1 micrograms per kilogram. So a starting dose for this patient could be something like 50 to 75 micrograms of fentanyl as a pre-treatment agent. Subsequent to the systemic opioid, the induction agent can be given in succession. Now, in the case of propofol, it does not provide any analgesia itself, and hence the pre-treatment step is very important. Other agents do provide analgesia. Propofol is a fairly rapid-acting agent, and again, in the shocked patient, the dose is very different. Normal dosing of propofol is 1.5 to 3 milligrams per kilogram. However, in patients that are shocked, the dose will be changed to approximately 0.2 to 0.5 milligrams per kilogram. Therefore, for the case of our patient, assuming 100 kilogram weight, we will give 0.5 milligrams per kilogram or 50 micrograms of fentanyl, followed by a bolus push of 20 milligrams of propofol for a titrated effect. This will be then followed with paralytics. What is important is that medications used for induction usually have systemic consequences. In the case of propofol, this includes negative inotropy, negative chronotropy, and vasodilatation. And it's important to be prepared for that. So, having a bolus of fluids at the ready, use of phenylephrine syringes, which is provided to you in the ICU as a premix of approximately 100 micrograms per cc, which is a pure alpha agonist, provides for you mechanisms of combating the adverse events of the induction agents. And so it would not be wrong, as you're giving the induction agent, to give 1 or 2 cc's of phenylephrine to counteract that hypotension that you can surely expect with this medication. An older and less used combination for induction agent can be fentanyl and midazolam. However, midazolam may be given at a dose of approximately 1 to 2 milligrams in a patient that is shocked, and this causes some element of anxiolysis. If this dose causes a drop in blood pressure, then one is even more aware of how critically ill this patient is. Typically, midazolam at these doses does not provide hypotension, but what is important is one needs to wait approximately 3 to 5 minutes for its drug effect to actually work. Once again, a systemic agent can be given, again fentanyl, after you have given the Versed and waited, and once again, topicalizing that airway will allow the patient to tolerate all of this better. Another drug choice for induction is ketamine. When using ketamine, you do not need to use any additional analgesia, such as systemic fentanyl, given that it provides analgesia and does this in a rapid-acting manner. Ketamine works on the order of tens of seconds and has an effect that lasts approximately 20 minutes. Topicalization of the airway can still be used with ketamine. Ketamine is an interesting drug in that it has various dose regimens. There is the subdissociative dose between 0.1 mg per kilogram, the middle ground dose of 0.25 to 1.5 milligrams per kilogram, and a dissociative dose greater than 2 milligrams per kilogram. The middle ground dose of 0.5 to 1.5 milligrams per kilogram can be used as a sole induction agent. It's important to note that ketamine is a direct myocardial suppressant, but usually not at the doses in the middle ground zone. In addition, ketamine does provide a sympathetic surge with tachycardia, and hence it is fairly hemodynamically neutral. However, to use this medication, you need to have some familiarity with it, and it's not the typical medication you will be seeing during the process of rapid induction. It was previously believed that ketamine is not an ideal drug in cases of elevated ICP or trauma. However, this has been disproven given its hemodynamically neutral profile. In a patient that's floridly tachycardic or hypertensive, ketamine may not be the best choice given that it does cause a sympathetic surge. Now let's talk about paralytics. When you're thinking about muscle relaxants, there are typically two drugs that come to mind: succinylcholine and rocuronium. Succinylcholine is usually given at a dose of 2 milligrams per kilogram and has some very important contraindications. Essentially, any patient with recent neurologic illness or chronic neurologic illness in the form of myopathies or neuromuscular disease can be excluded from the use of succinylcholine. And this is due to the fact that it causes in these patients a high rebound hyperkalemia. In a normal patient, succinylcholine causes an elevation in serum potassium levels of approximately 0.5 millimoles per liter. The other problem with succinylcholine is that it provides a false sense of security. It is believed that the effects of succinylcholine are both rapid-acting and shortly lived. However, studies show that in patients that are critically ill, even a regular dose of succinylcholine causes apnea times of greater than 5 minutes. In addition, in patients that the effect wears off less than 5 minutes, for example, the effect may wear off after 2 to 3 minutes, sometimes laryngoscopy and endotracheal tube delivery is not able to be achieved in that time, and a second dose is provided. And we do know that complications of succinylcholine do become more apparent with the third or second dose that can be given. Overall, it is a difficult drug to use in the critically ill patient given that you do not know anything about their past medical history or possible contraindications. In addition, as mentioned, it provides a false sense of security. A much better drug is rocuronium. Rocuronium is typically dosed at 1.2 milligrams per kilogram. Previously, it used to be dosed at 0.6 milligrams per kilogram, which is why it was believed that rocuronium's actions were slow compared to succinylcholine. However, if you use a dose of 1.2 milligrams per kilogram or even a higher dose of 1.6 milligrams per kilogram in a shocked patient, this achieves muscle relaxation in approximately 1 minute. A vial of rocuronium is 50 milligrams per 5 cc's, and therefore in our patient we would give 2 vials or 10 cc's equivalent to 100 milligrams of rocuronium. The other important thing about rocuronium is that it provides paralysis for 40 minutes. This is in two ways a double-edged sword, but an important adjunct. Firstly, it commits you to the airway. Once giving the muscle relaxant, you know that the patient is not going to have airway reflexes, and of course it's important at that point to be able to deliver the endotracheal tube. In addition, there is no need to give second doses, as you know the patient is properly paralyzed for intubation. Again, if the steps with induction and pre-treatment and oxygenation are all followed, the patient will be safe both hemodynamically and from an oxygenation perspective during this paralysis. Overall, remember to dose smart and plan ahead for the consequences of induction agents. Let's take a moment to pause as we've covered a lot. We have encountered a patient in septic shock who is not mentating properly. In addition, he is tachycardic and hypotensive. We have noticed that he has no major difficulties with his airway in the sense that there are no obstructions, no previous surgeries or previous treatments. His airway examination and mouth opening appear to be fairly unremarkable at this time. We're going to pre-oxygenate him in an upright manner using high-flow nasal oxygen underneath a 100% non-rebreather. In addition, we're going to have a bag valve mask ventilator at the ready. When he is induced, he's going to be ventilated in that manner with a two-handed technique. For induction, we're going to use rapid sequence induction. He is going to receive 50 microgram push of fentanyl after airway topicalization, followed by propofol, 20 milligrams followed by rocuronium 100 milligrams. At this point, he will be laid flat, a few ventilated breaths will be delivered, and then we will proceed with laryngoscopy. Let's now talk about laryngoscopy and the actual act of intubation. Airway difficulty can be described as both difficulty with ventilation of the upper airway, this can be with a bag valve mask or a supraglottic airway such as an LMA, or difficulty with the actual tracheal intubation itself, including laryngoscopy. And of course, difficulty with both of these things can occur during intubation, and that certainly marks a difficult airway. Airway emergencies can occur during your critical care rotation. It's important that if you encounter an airway emergency to try to remain calm. As calm as possible will help you do the right things and be able to think correctly and proceed in a regimented manner. So, make sure you call for help early. Your ICU fellow, the respiratory therapists, anesthesia residents, and in fact the anesthesia staff are all good resources. Respiratory therapists in the unit usually have a lot of experience with airway emergencies and are mostly able to deliver an endotracheal tube in the case that you are not able to. In addition, anesthesia residents and in fact the anesthesia staff may be in the building due to an emergency case, and then you again have backup. Don't be afraid to ask for anesthesia overhead stat or a stat page if that is the case. Let's talk about preparing for intubation, and doing so always means that you have to have adjuncts or backup plans both either in the room or outside the room. Every time you go for an intubation, it's important to have various sizes of endotracheal tubes with you. So usual sizes are 7.5 for females and 8 for males. However, some females will need 7 size tubes and some males will need 7.5 size tubes. ICU tubes are different than OR tubes in that they have a suction port that sits right above the cuff, and in fact the outer diameter of the tube is usually half a size larger. So it's important to have different sizes because at times if you can't pass the tube, one of your next steps aside from adjusting positioning or changing to a different device will be to downsize your tube. Having a laryngeal mask airway is critical, as we've spoken about previously in this podcast, for oxygenation, and you should be familiar with the use of laryngeal mask airways, and we'll cover this again in a different topic. Laryngeal mask airways are a good adjunct to oxygenation. They can be inserted fairly easily, and they come in various sizes, with size 4 and 5 being sort of standard sizes, and can be used to pre-oxygenate the patient or deliver an airway in the case that an endotracheal tube cannot be delivered. As mentioned earlier, you can approach intubations like anything else, so if the patient is freshly out of the OR or recently had a procedure, it's prudent to look at the old anesthesia record, and this may provide you with valuable information about the degree of difficulty of that airway and the types of devices that they used to successfully intubate that patient previously. Looking for signs of trouble during the actual attempt of intubation is of course paramount. Things like stridor, facial swelling, a large tongue, neck swelling, tracheal deviation, or difficulty with neck movement, agitation, and secretions are all important considerations. This is the familiar Mallampati score. This image also outlines the challenges in some patients with the presence of facial hair that will not necessarily impair mouth opening, but may have a consequence for bag valve mask ventilation. Maintenance of the airway can be done by chin lift and jaw thrust. Some of this is going to be happening during bag valve mask ventilation. In addition, you can appreciate that the size of the chin, the anatomy of the chin itself, the presence or absence of facial hair, and of course, as we alluded to before, the presence of false teeth or dentures all impact the consideration that you must be making during laryngoscopy. And so it's important to remove anything that's going to be obstructing the airway. It's important to have all of those considerations, and we've already talked about the fact that you're going to have your airway adjuncts ready in case you encounter other problems. Let's take a moment to recap some of the items we've discussed. What are the difficulties this patient is going to be having during the time you're going to be doing their intubation? Are they going to have difficulty with oxygenation? Well, hopefully we've been thinking about that and have instituted some management changes. Are you going to be putting in an LMA and then asking for help immediately? Are you going to be switching from a direct to a glide scope? Or there's going to be a lot of emesis or blood in the airway, in which case a glide scope as your first choice was not very useful. In fact, you should be switching to direct laryngoscopy. If passing the tube is a problem, are you going to be making an attempt with a smaller size tube? And if the patient is hard to ventilate, what other considerations do you have to make? Are there going to be a full stomach? Are there going to be other things that need to be done? For example, do they have on a recent chest x-ray a large dilated gastric air bubble, in which case decompressing that will be improving your profile both for intubation and post-intubation ventilation. The items that we discussed represent some of the things you may be considering if you have the luxury of time to consider them. In some situations, the patient may not be ventilating, in which case you will have to act immediately and establish an airway. Let's talk about positioning. Patients more and more are obese, and selecting your modality and positioning the patient are very important in actually being able to deliver that endotracheal tube. So for patients that are obese, and in fact any patient, what you want is, as you've heard, the sniffing position. And that position can be best described when you look at the side of the patient. For the ear, the tragus of the ear to be at the level of the sternal notch. And to accomplish that in a large patient, you need to have a pillow under the head, in fact probably several pillows, and sometimes pillows under the shoulders and back. As well, this positioning is called the ramp protocol and will give you a great view for actual laryngoscopy. Now you're ready to insert the actual laryngoscope into the patient's mouth. At this point, the laryngoscope blade is introduced into the mouth with gentle, slow movement. The tongue is controlled as the blade stays midline. The blade is advanced slowly as the tip of that blade inserts into the vallecula. At this point, you engage in a gentle lifting action, which in some patients does require a fair amount of force, lifting the patient's chin forward towards the ceiling. It is good posture to have the left forearm tucked in towards the body during that time. An important note for video laryngoscopes, such as a glide scope, this is much more of a wrist action than an actual lifting action of the patient. There also needs to be at this point some manipulation with your right hand after maybe a suction of the thyroid cartilage. This is so-called burp maneuver, backward, upward, rightward pressure. There is no precise movement that you need to do. In fact, you just need to manipulate that thyroid cartilage and airway so you get the best view. At that time, you can then ask a colleague, for example, the respiratory therapist or RN, to place their hand where you had your hand to maintain that view. At this point, again, in a controlled manner, you can go ahead and advance that endotracheal tube. The actual act of laryngoscopy is supposed to be a predictable and progressive sequence of steps. It should start with visualization of the tongue and uvula, the control of the tongue by keeping the blade midline, visualization of the epiglottis, and then the posterior cartilages, the interarytenoid notch, the glottic opening, and with insertion of the tip of that laryngoscope into the vallecula and a lifting action, the viewing of the vocal cords. Here's a view of what you'd expect during laryngoscopy. You can see the epiglottis, you can see the false cords, you can see the true cords, and the posterior cartilages. These are the views that can be described for laryngoscopy once you have the laryngeal view, and these are the so-called Cormac-Lehane laryngeal grades. And again, this is important to note as you'll be documenting this in the post-intubation record, and certainly grade 3 to 4 views mark a difficult airway. Let's talk briefly about the endotracheal tube itself. You'll be handed the tube by the respiratory therapist with lubrication already on the tube, certainly towards the front of the tube where the cuff is. It's also important to make sure that your stylet is lubricated so that there's no inadvertent extubation of the patient once you've actually successfully passed the tube. Now, there is a technique called straight to cuff and then a 30-degree bend at that cuff for direct laryngoscopy, and this is supposed to help your first pass success. In the case of video laryngoscopy, the endotracheal tube can be bent to the shape of the actual glidoscope, either using the glide scope stylet, which is a rigid stylet, or the stylet can be bent with the help of your hand to the shape of the actual glide scope laryngoscope, and that way you can have a good first pass technique. Now, advancing the endotracheal tube with a glide scope is an advanced maneuver and will be covered in a different podcast, but here is a link. Just a word on video laryngoscopy. So there is some notion out there that the video laryngoscopy sometimes can cause difficulty in first pass or cause a length of time to be increased for delivery of the endotracheal tube, and this is in fact not the case. Video laryngoscopy has been shown to have higher improvement of first successful intubations and first attempt intubations, and doesn't usually add additional time in the hands of an experienced provider. What is important to note, however, as we've alluded to earlier, is in cases that there are a lot of other things in the airway, such as secretions, blood, sometimes these things can very quickly obscure the view from the video laryngoscope, in which case it becomes a useless device, and in that case, sometimes direct is actually better. Typically, as you're developing your skills, it's important to gain those skills with a direct laryngoscope, And that's because the direct laryngoscope is what you have on the floor readily available in the airway boxes. And in fact, in the crash airway situation, when a patient is not ventilating and obtunded, for example, doing a cardiopulmonary arrest, you certainly are just going to have a laryngoscope. So it's always good to develop your laryngoscopy with a direct laryngoscope and then to learn how to use video-assisted devices such as a glide scope. After the patient is successfully intubated, there is often some neglect of the post-intubation care. Remember that once the patient has been delivered an endotracheal tube, they have two things going on: sympatholysis in addition to the direct effect of the medications, causing post-intubation hypotension. And it's important to be ready for that, once again, by starting the vasopressors early and supplementing volume. The other thing that occurs is now the patient has gone from negative pressure ventilation to positive pressure ventilation, and the increase in intrathoracic pressure causes decreased return to the right side of the heart, and that decreased return causes hypotension. Lastly, the patient has now been intubated and the drugs are going to wear off depending on the choice that you used. If propofol was used, its actions for induction are going to be removed fairly quickly, and so will analgesia agents such as fentanyl. Therefore, the patient is going to need a bolus of some other medication, whether that's going to be a hydromorph or midazolam or more propofol. Those need to be given after the post-induction period. Typically, you use the drug that you're going to use as a drip. So, for example, if the patient was successfully intubated with propofol and you're planning on keeping them sedated with propofol, it's important to have that drip ready after they've been intubated. Okay, we're in the final stretch, folks. Let's recap what we have learned. We have been called to the floor to see a patient that's critically ill with septic shock. They're not mentating well and they have abnormal vitals. Importantly, they're tachycardic and hypotensive with abnormal saturations with supplemental oxygen. You're going to approach this airway with trying to understand if there's any previous record of their airway with any known difficulty. If not, you're going to use common sense. You're going to assess mouth opening, presence of foreign body, abnormal anatomy, facial hair, things of that nature. You're going to have your consideration focused on oxygenation, laryngoscopy, and their hemodynamics. With regards to oxygenation, you're going to perform with a high-flow nasal prong oxygen delivered underneath the mask. You're going to use a non-rebreather mask. If you need to have additional oxygenation or ventilation, a BVM could be used. The BVM breaths can be given with the patient's own breathing if they have some respiratory effort. At this point, you're also going to think about their positioning using ramp protocol. Then you're going to do your rapid sequence induction. You're going to use topicalization of the upper airway as a induction agent sparing maneuver. You're going to use fentanyl, propofol, and your muscle relaxant. At that point, the patient is going to be put in a recumbent position. You may have already given some fluid or phenylephrine to support their hemodynamics, given that you've given an agent that's going to alter their hemodynamics. At this point, you can go ahead and engage in laryngoscopy or deliver some BVM breaths if the patient is not satting adequately. At this point, you're going to make sure you've already done some pre-oxygenation for a minimum of 3 minutes, and now you're into laryngoscopy. As mentioned, careful, direct, progressive approach into the airway. You're going to have your airway adjuncts, for example, a smaller size tube, an LMA, and a video laryngoscope. And you're going to try with direct laryngoscopy. If that attempt is successful, fantastic. Endotracheal tube is passed. At this point, you're not going to forget about your post-endotracheal tube management, which includes hemodynamic support, oxygenation support, and sedation. And after this, you're going to document your technique in addition to obtaining a chest x-ray and transferring the patient to a ventilated bed. So this was an overall approach to a patient who's critically ill with thinking about all of the different aspects that you need to consider. And we hope that this is a starting point for you. Lastly, the Canadian Airway Management Guidelines from the Canadian Journal of Anesthesiology are a good resource. There's a Part 1 and Part 2 document. This will be available on our website as well. In addition, the Americans have American Society of Anesthesiologists Practical Guidelines for Difficult Airway Management, and these again are very good documents with algorithms and considerations that you can use. We thank you for joining us for this podcast and look forward to future sessions. These will be followed by ventilator basics and ventilator emergencies at a later time. And thank you and good luck on your airway management in the critically ill patients in our ICU units. Bye for now.